Mike Miranda.
Good morning. Hope everybody can hear me. Mark, thank you for that. I feel similarly. I'm so pleased and honored to be associated and to call you all my friends and to learn from each other as we go through this journey. It's really a consistently exciting thing to do, and it's really the fabric of my professional life. So I'm going to talk to you all this morning about rotational deformity of the proximal femur, look at the indications for osteotomy and technique. Brett went over the disclosures. At the end of this session, the learner should be able to understand the importance of some objective data in evaluating malrotation, understand the indications for surgical intervention, understand the various techniques available for managing this problem surgically. So we're going to start off with a case. This is a woman. At the time, she was 56 years old. She was 8 years status post a motor vehicle accident, and she had suffered a number of different injuries. The one that's pertinent to our discussion is she had a right intertrochanteric hip fracture. It was initially managed with a trochanteric femoral nail, and the nail went on to be removed due to persistent pain. She went on to relocate, moved locally, and she presented to my office with complaints of a painful gait. Her complaints otherwise were anterior knee pain, thigh pain, weakness, and difficulty with endurance when walking. She noted that she couldn't make it through the grocery store without having to stop and rest. Now, this is her gait. She has a contralateral tibial talar fusion, but you can see here that she has an internal foot progression angle, which is different, right? She has a prolonged stance phase, or it's her right side that we're looking for, and she has some weakness in her pelvic stabilizers. So you can understand why she would have a problem. This is her physical exam with regard to rotation. So she's got some marked asymmetry with regard to her rotation. AB and E deduction is mildly different, but not as impressive as the discrepancy in her rotation. These are her x-rays. When you look, you can see that obviously she's got a deformity of her proximal femur. You look at the lateral and you're fooled somewhat into thinking that it looks pretty good, when in actuality later on I'll show you that it's markedly displaced. This is a computer scanogram. I don't have a formal scanogram for you, but it can show that in general her overall alignment isn't bad. It's off, seems like it's in a little bit of valgus. And again, it's something to take in and use that data to help you make some decisions. Her CT scan shows some discrepancies, okay? So you can see this is a fairly complex case, right? So when you evaluate these patients, you have to take that information, or at least I would encourage people to do this, create a problem list, look at your indications for intervention, look at the opportunities, the different techniques to put them together and create a plan of treatment that you present to these patients later on. For these folks, I usually evaluate them and on a separate occasion, come up with a plan, a separate occasion, have them come back and discuss that plan. So you need time to sort of chew on this stuff, and that's what I do. So let's go over some of the highlights in the evaluation, and I'm taking it back a couple of levels just because these patients walk into your office and you need to understand that if it's a malrotation problem, there are certain things that you need to pick up on history, physical exam, as well as the imaging. So the current symptoms are really important because you want to make sure that you address them to the patient's satisfaction. You need to understand the injury, the treatment, their physical exam. We'll talk a little bit about that, the x-rays, as well as the CT scan. With regard to history, malrotation patients can have very vague symptoms. This woman, she has anterior knee pain, thigh pain, weakness, poor endurance. I mean, that's a number of different potential etiologies. Could have just been poor rehab, right? She has some quad weakness that gives her some anterior pain. She could have a missed injury. She could have poor endurance because of her cardiac system or another system, or she could have had a patellofemoral injury like so many of our femur fractures do. So there's a lot of different reasons why malrotation can be missed just on the history. So this is a woman, this is a prime example. This is a really wonderful lady. She came into my office. She had seen a couple of other folks, and her chief complaint was fatigue with walking. And even though she has a fairly significant external rotation deformity, it wasn't picked up. And I'm not trying to fault anyone else. I'm just saying that you really have to look for what the patient is complaining about and try and assure that there's no pathology there. So their symptoms are inconsistent. Why? And it's because patients have different thresholds for tolerating malrotation. A lot of this has to do with their pre-injury hip rotation, but also the direction of the deformity affects tolerance. So if you have a minor malrotation from 10 to 14 degrees, only 3 out of 26 patients in one study had complaints. If you have a greater than 15-degree difference, only 8 out of 21. So you can see that they're able to tolerate a fair amount of displacement. Symptoms, again, anterior knee pain, usually seen with stair climbing, running, and sports. And if consistently, if you have a 10-degree, greater than 10-degree external rotation deformity, you have some patellofemoral joint symptoms. So these folks will come in, they'll complain of anterior knee pain. You'll think, oh my goodness, just another patellofemoral problem, send them out on their way, but really they have another issue. On physical exam, you can evaluate these folks a number of different ways. You can evaluate them. The patient could be supine with the hip extended, the knee extended, supine, hip flexed, knee flexed, prone with the hip extended and the knee flexed. Which one of these is better? Well, you can see this is a hip extended, knee extended. This is Dr. Bird doing an exam, hip flexed, knee flexed. And this is another patient prone with the hip extended and the knee flexed, okay? Turns out that the prone exam is actually the most sensitive for picking up the degree of discrepancy between the sides. How sensitive is each of those exams to picking up or to the measurement that you might find on CT? It's actually 20 degrees off in one study fairly consistently. So it's one of those things that that's why you need to have to get the data. We're going to talk about that a little bit more. With regard to physical exam and gait, these folks have a characteristic type of gait. When you look at gait, you want to make sure that you look at the foot progression angle, try and have an understanding of where the knee is, and trying to get some idea or sense what's going on in the hip. So the priorities for gait, your body wants to maintain the foot progression angle. Next, it'll have the knee axis perpendicular to the plane of motion. And then lastly, the hip will rotate to accommodate to maintain the other two. So again, just saying this differently, if you've got a deformity, you're going to notice that there's hip changes in the hip rotation first. Next, it'll sacrifice that knee axis, but it'll do everything to keep that foot progression angle within 0 to 6 degrees. So that means if you see somebody and if their foot progression angle is off, they're already at the end of their capacity for tolerating that and for trying to accommodate to that. You'll see with these folks with malrotations, especially external rotation deformities, they'll have a flexion movement acting at the knee. When there's flexion movement, the quadriceps fires during the heel strike and the foot flat. So why does this happen? You'll see some external rotation. The line of force falls behind the knee, resulting in the quadriceps firing. So this is a patient of mine. She was 32 years old when she presented. She was 16 years status post to derotation for excessive vanaversion. She was treated with an IM nail, which had been since removed. She had a significant external rotation deformity on examination. She had bilateral flat feet, some comorbidities, HIV, obesity. And here we go. This is her exam. Now this is her gait. So she can see that she has a shortened stance phase. She has pelvic tilt and she rotates forward. She flexes at the waist to push forward to get her center of gravity anteriorly. And the result of that is she gets a forced knee hyperextension. So it's very, very confusing exam, but if you start to become familiar with the pattern, you can pick this up. So it's worthwhile understanding what's going on with the patient's gait in order to try and evaluate how the deformity is creating dysfunction, and then how you can resolve that dysfunction by correcting the deformity. So radiographic evaluation, CT is the gold standard. How did we get there? Well, we know that the physical exam has really a poor correlation with the actual torsion. Plain radiographs. The Dunn method is one way you can evaluate patients' rotation. This is very, very technique dependent, and so is really for historical purposes only. And you can see here on some of the, just a change, gentle change in the position will give you a different idea of how what the antetorsion is. Ultrasound is another way, but it's very, very tech dependent. And that's why we've become for CTs to become the gold standard. And we use the method of gene mark, but there's a number of different ways that have been described. This is the one that is most consistently recommended and recognized as the way to go. So there is some intra-observer differences. These can be as much as 15 degrees, and they're shown to be highly dependent not only on the CT slice, but where the particular observer draws that line. And so if you all were with us last week and the week before, last week, Raul had mentioned in bone centers that you can use the hip center tool to help identify not only the hip center, but also the center of the femoral neck. I find that's extremely something that's consistent and dependable. So that's really helpful. The MedCAD programmer that Maurizio had used is also excellent with regard to that. Uses a slightly different technique, but again, consistent. So you want to use digital programs to help you to identify these and determine the degree of deformity. So next, with regard to indications for these patients, you have to really look at the patient's complaints with regard to their malrotation, understand the deformity. You want to create that plan and then review that plan. The indications for surgery for malrotations are rarely absolute. We'll go through what the current recommendations are. But patients are also, their complaints are are very, very important. You want to make sure that you understand where their pain's coming from and the degree of dysfunction. Remember that there are some folks who will have some type of abnormalities, and this is dysmorphia, that's a psychological issue. You want to make sure that you recognize this so that you can satisfy the patient and make sure that you have a proper indication for intervention. So it's critical that you understand that chief complaint so you can address not only the patient's concerns, either surgically, or make sure that you modify their expectations so that they end up being satisfied with the interaction. So with regard to malrotation, the question is the deviation inside or outside of a bell-shaped curve? Well, we know that from CT-based studies, 95% of mature healthy population has less than 11 degrees difference femoral anteversion. 99% of the population will be less than 15 degrees. So in general, most folks have taken the position that a difference of 15 degrees or more is considered having a true rotational malalignment. Internal versus external rotation, are they the same if there's, or it should be malrotation, right? So the foot progression analysis indicates that external malrotation is much more difficult to overcome than internal malrotation. Patients with external rotation and malrotation greater than 20 degrees scored worse on functional outcome scores and had more difficulty climbing stairs than internal rotation. Now on to technique. We've seen a lot about technique this morning, some amazing cases that I wish I could call my own. Were always fun to look at. So this particular table is something that I organized, and it helps me think, because when I create my problem list, I want to be able to go back and look and have this as a reference. And something that I can use to help me decide where I'm going to go and how I'm going to create my correction. So in the proximal femur, it's uncommon to see simple malrotations. They're often combined with other deformities. And the reason why is because the femur is a curved bone. It's not a straight bone. In other words, its mechanical and anatomic axes are different. And so as a result, the deforming forces often cause displacement in other planes, in more than one plane. And so your plan should be to resolve the other deformities and then address malrotation. As a result, you need to have an osteotomy that ends up being transverse. That's the way to simplify it. There are complex single plane osteotomies which can be created and determined mathematically. I find that process burdensome and very, very challenging Frankly, I just don't think I have the cortex, the cerebral cortex to accommodate it. And so I break it down to the simple planes and fix it that way. So let's get back to our original case. We've got our 56-year-old woman. She's got this deformity on her x-rays, and this is her CT scan. I think this is probably the most helpful portion, and I enjoy looking at 3D CTs of deformities. It really helps my brain figure things out and get it wrapped around. So that you can see that she's got an intertrochanteric fracture which was displaced and rotated. So you can see she's got some prominent bony landmarks. So intraoperatively, I know that that's going to help me out. So when I created her problem list, and you see that she's got 45 degrees of interrotation. She's got a seaming varus of 16 degrees. She does have some translation of that of the distal fragment laterally, just slight, and she's got a leg length discrepancy. But the leg length discrepancy is from her contralateral tibial talar fusion. So when we start looking at these and trying to correct this, remember we want to create corrections that leave us with a transverse osteotomy so that we can affect the rotation afterwards. So if we do a varus closing wedge osteotomy laterally, that's essentially a valgusization osteotomy. This has the potential to lose some height and actually will help the leg length discrepancy on our contralateral side. And it'll also leave us with a transverse osteotomy. What's next in the line of thinking? What implant am I going to use in order to fix this? Because I'm creating, or I'll end up with a very simple fracture line or osteotomy line, I would like to create compression, and so I'm going to use a blade plate. If there's different circumstances, you may pick out a different implant. In this situation, I chose a blade plate. And this was my plan. And this is the execution, and this is the execution you've seen with previously. We've got distal reference wires, we've got a proximal wire, and I use the metal triangles that are available in the osteotomy set. You set up the blade with the chisel and set my blade in. Remember I essentially put the chisel in, back that out, set up my osteotomy with wires. Now, unlike Roger, I actually ride the wires with my saw, and I think that's probably a certain comfort level. Roger's a master technician. He's able to freehand it and make them look beautiful. For me, I depend on those wires, and so I'll ride the wire and then drive in the plate before I finish my osteotomies. Okay, get everything all set, and then do my rotation, and then compress it, assuring that I've got a satisfactory derotation. I check alignment, make sure everything looks good, and then it's our final. Let's look at another case. This is a young man, 38 years old, had a history of a femur fracture when he was young, age 12. He was treated closed. He developed avascular necrosis, and he was actually referred by one of my partners. He was referred by my arthroplasty partner for potential osteotomy in order to resolve his malalignment before proceeding with the total hip. So you can see here he's got some flexion, 17 degrees. He's got varus at 13 degrees, and he's malrotated 10 degrees. He's got a relatively minor malrotation, but still, if I'm going to fix it, I'm going to just try and get as much done as possible. So I've got my problem list here. He's got a 2-centimeter leg length discrepancy, AVN of the hip. He needs a total hip. And so all that's going to come into play as we're going through the thought process of how I'm going to execute this. He's got a leg length discrepancy. I know he doesn't want to rock the Herman Munster boot. So I'll try and address it if I can. But the reality is that if the only way to resolve that is to create an opening wedge. Well, opening wedge osteotomies in the lower extremity are inherently unstable. Plus, it's very, very difficult to do rotation because you'll have very, very little bony contact. So unfortunately, I can't do that. I'm going to have to do a closing wedge osteotomy. So I also need to make sure that he gets set up for his total hip. because that's the next step. So I'm going to try and avoid a plate, and I'm going to use a nail to fix this. Also, the nail assures that the ultimate architecture is going to be able to get an implant down into the across the osteotomy site and fix it with his total hip. And so you can see here again, using my going back and looking at my table, it's very helpful. So we're going to do a closing wedge osteotomy, derotation, and fix it with a nail. And you can see here fairly quickly, we'll go through. So essentially we start the nail, get everything all set there, get your osteotomy all set. I use, for some of these osteotomies, a very convenient way to do it is to take the small X-fix set, and the one that's for the hand and wrist, use 4 O'Shan's pins from there, put those in, and then set the angle that I want to correct. In this case, derotate internal rotation. So there's 10 degree difference between the proximal segment, distal segment pins, and then derotate, and then set up my nail, and then end up finishing. And then he goes on to get his arthroplasty by my partner. So the take-home points for this particular talk are that symptoms and malrotations can be vague. It's really helpful to use digital software to measure the differences. This way you can be consistent. And you want to make sure that you understand the patient's concern and individualize your treatment to fit the patient's needs, and do so via a problem list. Thanks for your attention.